Hello, everyone. This is Danielle Sartori, Doctor of Physical Therapy, coming to you live from the knee joint. We also have with us here Nick Ramos. He is a student at UCSF getting his doctorate in physical therapy and is currently here on his internship. And while he was here, has encountered a few patients that have patellar clunk syndrome as a complication of their total knee arthroplasty or their knee replacement, and it intrigued him. So, for his presentation during his internship, he decided to do a little research and bring it to you all. So, I'm now going to turn the tables to him, and he is going to share some slides with you and hopefully help you understand what patellar clunk is and if you're having any symptoms of it.
All right. So for me, let me go ahead and share that PowerPoint. Okay. So patellar clunk syndrome, what we're going to end up looking at, and what I thought would be useful for you all is if you had these symptoms come up, to be able to have a conversation with us or even with your doctor who ends up performing the surgery. And so that way you can end up figuring out which route would actually be best for you. So, patellar clunk syndrome, what is it? We're going to start off with just with a quick overview of what we're going to be talking today. So, an introduction and looking at the prevalence, how common does this actually occur? Then we'll go into the anatomy and mechanisms of it all. We'll end up going into some common causes, differential diagnosis that Danielle would end up looking at for you, treatment options that you can use, and then what the prognosis looks like. How far out does the recovery process for this complication have? So, what is patellar clunk syndrome? It's a complication following a total knee replacement. It's characterized by either a non-painful or painful clunk or pop sound, and typically includes a sensation of instability in the knee. Now, where this clunk is usually felt, it's felt from starting in extension. So if you go from flexion, a full flex position, you extend out, you'd end up feeling that painful range or even the clunk at around 30 to 45 degrees. So right here. So if we start from full flexion, go out, you end up feeling it right in the middle. Okay. And typically, this presents 3 to 12 months after surgery, but at most, I think there was one case study that was shown in the research that showed that it was as far as 2 years, but typically it's within those earlier phases of rehab. Incidence rate is predicted to be between 0 and 20%. And the reason why that's such a big range is because 0% would be a total knee replacement without a what's called a posterior stabilized component. We'll get into that in a second. But typically, this higher 20% is for that posterior stabilized total knee replacement. And so, if we look at the anatomy and mechanism on the pictures on the right of the screen, the top picture shows what a normal, typical knee replacement is on the left side. On the right side, it's the posterior stabilizing knee replacement. So if you could kind of see, there's a button that actually fits into the hole for that posterior stabilizing in order to make the knee feel more stable. Now, this doesn't mean because there's a higher prevalence that you might not be indicated for this type of knee replacement. What this is saying is more that when you have the discussion with your doctor about what knee replacement works best for me, they're going to take a look at your alignment, whether or not you're colloquially called knock-kneed, or if you're excessively bow-legged. They might need to actually put this component in there to give you more stability and to make your alignment better. But there does lead to a higher cause of this syndrome happening because there's more space for that fibrous nodule to get stuck in. And so if we look at what the anatomy is, it's the formation of a fibrous nodule of scar tissue post-surgery between the patella and the femur that can lead to patellar clunk syndrome. So on that bottom left picture, if we look at that top black circle, That's where we end up seeing where this patellar clunk syndrome ends up developing into a problem. So again, as I had said earlier, as the knee extends and the patella tracks through that middle section where there's a hole on the knee replacement, it can get stuck in there. And so as we extend out into full extension, you'd end up feeling the clunk. And it could be painful, it could not be painful. It just depends on how much fibrous tissue is actually there. So on the bottom right, we could end up seeing that. That's a lot of tissue that needs to end up getting resected out. And so that is a common formation that occurs at that top of the patella where the quadriceps tendon or that big band right above this patella ends up attaching. Okay. So, what are the causes of this? So, if we end up looking at what leads to patellar clunk syndrome, the most common would be the prosthetic design and its implementation. So, because there's that hole and it's a little bit bigger, so if we look back at this slide, the top right is the posterior stabilized total knee replacement. Because the height is greater than that of the typical knee replacement, there's just more room for it to get stuck in. So it might not get stuck at the beginning stages from being in this flex position and extending out. It might actually get stuck a little bit later because of that height difference. Similar to that, there are certain components that they'll put into your knee. So this is less about what you end up deciding, but more when they're actually doing the surgery, what they're deciding actually fits for your knee. So that way it can actually work well within your knee. So that patella, if we end up looking here, there's a button on the bottom left picture that is on your patella bone. Okay. On that patella bone, if that button is too small, it could cause the formation of that fibrous nodule because it's pretty much being pulled by that quad tendon. And then similarly, there's a spacer that goes in between the two knee replacement parts. If that is too thick, then your patella is going to be a little bit shorter in terms of it's not going to fit directly in the middle. It's going to fit a little bit lower on your leg. And so it just gives it more ability to get caught in that one range where it's inside the nook of that knee replacement. Some other causes would be if we have less strength at the time that we end up gaining our range of motion, we could have some mistracking issues in terms of if our patella is super, super stiff and it doesn't want to actually track upwards as we go into that extension, and then it could get stuck in that lower position rather than moving up. And then finally, I think just with all surgeries, there's going to be the formation of scar tissue and whether or not it lays down and how it lays down and how much of it, then that can end up creating a complication. But that's where we would have to refer out to a medical doctor and to end up getting some imaging done. So that way they can either do an ultrasound or an MRI to see how much of that fibrous tissue is there and if it needs to be taken out. So this is more for a PT perspective as to what could be happening to. Sometimes the pain end is mimicking PFPS, which is patellofemoral pain syndrome, but that clunking sound is usually not a part of what PFPS is. It could be, but at the same time, the diagnostic are taken under your PT. Patellar tendonitis or quadriceps tendonitis. Patellar tendonitis, that's a little bit lower, so that would be below the patella. So if you're having pain below the patella, then it's probably closer to that rather than it being this. Quadriceps tendonitis is kind of in that same area, but usually you wouldn't have a clunk sound. Sometimes it might be a little bit of a popping sound, but again, we would have to end up looking at what range of motion it's actually occurring in. And then the final two has to deal with just the prosthetic itself. There still could be some knee joint instability if the ligaments were really lax and they end up using, instead of using a posterior stabilizer, they end up using just a different model. Then you could still have some joint instability there, or it could be a prosthetic failure. So if there was an incident that occurred that dislodged a piece, it would have to be a pretty traumatic event to happen, but then it could end up leading to this patellar clunk syndrome. So a couple treatment options that end up showing really good use in the literature. In terms of the first line treatment, the medical doctors and the medical field agrees that a arthroscopic removal of that scar tissue ends up showing the best type of benefits in terms of just they're able to actually get whatever that aching, painful feeling is out immediately, and then we could continue on with our physical therapy treatment. Um, or if it's something more from the surgical side in terms of they didn't resurface the area as much as they needed to, they'll go back in there and actually resurface it. Or if they need to adjust the alignment of the prosthetic too, because if you were super excessively knock-kneed or super excessively bow-legged, getting that position to be just right for you, it could end up leading to complications later down the line. In terms of conservative treatment, I do want to preface that the conservative treatment, in terms of quality of life, usually this is better for those that don't have the painful clunk. If they just have the clunk and it's non-painful, we could still work on the quadricep strengthening without it being painful. So getting the quadriceps strong so that way we can track more, improving the patellar tracking. And so we'll work on your glute muscles or your inner thigh muscles in order to make sure that those things that connect to your patella aren't tight and that they're able to actually move well with your whole leg that is moving accurately. So that way you don't have to rely on just the stability of the joint, but now you're using it and it's able to get out of that painful range or non-painful range, whichever one it is that's causing the clunk. And then finally, just improving the knee stability in itself through muscle exercises and muscle strengthening tends to help as well. Now, these two other points here, yes, it's in the literature in terms of how to treat patellar clunk syndrome, but I also think that it's the reason why most people end up getting knee replacement in the first place, in the fact that there's activities that they want to do. So although they say that you can, if you have patellar clunk syndrome, that you could modify your activities to do things that aren't causing it, the major reason for having the knee replacement in the first place is actually to do those activities. So if you are a case that, you know, you had a knee replacement and then now you're backtracking and you're thinking, you know what, I'm okay with just modifying the activity. Yes, you could end up being more conservative in your approach, but it would lead to you not being able to do those activities that you wanted to do by getting the knee replacement. So I feel like that was kind of a weird one that was put in there, but I just wanted to present on that as well. And then finally, pain management as well. So while you're waiting to create these options with your doctor, being able to take NSAIDs to decrease the inflammation from the just the pain that comes from the clunk, or even using a cortisone injection to decrease the inflammation in there, because sometimes the scar tissue from the synovial fluid that surrounds the knee is what's causing the irritation. So finally, if we end up looking at prognosis, so on the right here, we have a preoperative picture of one of our patients actually, in terms of the amount of just scar tissue that formed afterwards. And so this would be in that area above the patella. where the quadricep tendon attaches to the patella. All of that is some scar tissue there. And if you look at the bottom picture of the post-op, it's a lot more clean. It doesn't look like there's cauliflower in there, which is not what your knee should look like. It should look smooth and clean like this. So if we end up looking at prognosis, I think it's very important that you have a discussion with us and you have a discussion with your medical doctor about choosing the best outcome for the quality of life and activity tolerance that you want. So again, because you already went into a knee replacement, having these discussions or hopefully having these discussions, you should have an understanding of these 5 questions that I end up creating. So that way you can actually make a decision. Do I want to go more conservative or do I want to go more surgical? So the first one being, what do you need to do on a daily basis? Do you have stairs? Do you have a hike that you like to do? These are things that you have to take into consideration. Is it going to pull you away from that? Second, would you be able to confidently complete the activities you would need to complete or would like to participate in? So if you really like to go kayaking, being in that bent range and moving in and out of it, would that cause an issue? Will you be able to look past the noise sensation to strength train at a challenging level? I think this is probably the most important one because in order for us to get you back to the things that you want to do, you have to strength train at a challenging level. And so if we can't push your quadriceps muscles or the front of the thigh muscles more than what they need to be, then you will we will cease to actually strength train at a level to make our muscles do more work. And then that just leads down to the road of being deconditioned and doing less activity. And so we have to think about, are we able to look past the noise and the sensation and can we strength train without pain? And then can you confidently enter exit deep squat position to move on and off from a chair, car, or toilet? I think this is important just because it shows that the quality of life, in order for you to perform a deep knee squat, you have a better quality of life and you end up living longer if you're able to do these activities. And then finally, just in terms of the conversations that you have, are you satisfied with your knee replacement? If you're not satisfied with your knee replacement, then something needs to be done to actually make you satisfied with it. Part of the reason why you end up going into the knee replacement in the first place is to actually fix these problems and to get back to your activities. And if that isn't being met, then you have to have a discussion with your medical team in order to actually get you to where you want to be. And so I think that although this is a very rare condition that ends up coming up, the understanding that you can actually take a role in whether or not you want to go into surgery again to end up fixing this and have a better quality of life or actually working through it is important. And so I end up listing my resources here for if you wanted to read more into what patellar clunk syndrome is, but hopefully that's a good overview of what it is and what it would look like to actually rehabilitate it. So thank you.
All right, Nick, thank you so much for that information. One quick question. Did
Yeah.
you find any correlation between the 4 clients you have come across in your time at the knee joint with the patellofemoral clunk syndrome there?
So out of the 4 different clients that we actually had at the knee joint, the correlation as to the how quickly they got their patellar clunk syndrome kind of goes hand in hand with the recovery timelines based off of age. So our 2 younger clients, because they're able to get their range quicker and they're able to gain their strength back quicker, technically they end up getting it a little bit earlier than our 2 clients that are a little bit older. The reason that happens is because if we're actually working within those ranges to where now we can end up getting into more of that deep knee flexion position, as we extend out, there's more area and space for that fibrous nodule to actually get stuck in. So rather, it has less to do about the recovery process or the timeline, but it has more to do with the stage at what they are at, if that makes sense.
And any difference between males and females?
So it was kind of in a gray area in terms of the literature. It said that males are more prevalent to have it, but I also don't know if that reasoning is because males have more knee replacements or if they have a posterior stabilizing more often than women. So they didn't look at any of those comparisons. It just said that males are more likely to have it. And whether it's because of those reasons or it's because of scar tissue formation, I don't know.
And then our clients were two males, two females. So
Yeah.
it was 50-50 for us.
Yeah.
All right. Well, thank you for this time. We'll be adding this to a blog post and sharing with you all soon. All right. Thanks for tuning in. Bye.
All right. Bye, everyone.